before we move ahead as
No,
far as
everything looks
questions
like
or?
it's okay. I got all the questions cleared out.
Well, again, I sure appreciate you doing that. And
No problem.
I just want to remind everybody that, again, our big goal for the next for these first 3 days is to make sure that we identify what the important things that we need to be studying to prepare for the exam. All right. So again, most of the time as we go through the material, it's just pointing those things out to you. And you may feel like it's kind of a kind of a dull thing to do. But my goal is to make sure that you can identify what those things are in the study guide so that whenever we're done, you've got a roadmap in front of you. I mean, you know what's going to be the main thrust of the exam, all right? So that you can identify those things that you are familiar with and those things that you're not familiar with, so that you can make a decision in your studying plan. What are the things that you need to really work on, and which are the things that you don't really need to work on? So, I mean, that's what my goal is here for the next several days. And again, in this next section, there will probably be several things that we actually kind of slow down and look at and do some practice questions and things like that, because they're topics that may be a little bit more challenging and that we have found in our experience that people have difficulty with. And so I want to make sure that you've got some strategies and some things to use in your toolbox as you work through these and prepare for those types of questions on the exam. All right, so I am going to go ahead and back out of this, get me out of the way. And let's go ahead and let's start talking about the next page 21, X-rays. So we're on page 21, A21. The thing about radiographs on this test is that you're not going to have to be expected to be a radiologist. There's some basic terms and things that you should be familiar with, and some basic disease processes that you need to be familiar with, and how that typical X-ray may be described. And what we find as they test on this information, what we find is that here again, you may see it's kind of a 50-50 shot as to whether or not they will give you a picture or whether or not they'll describe the X-ray in words. So you have to kind of know both. You have to know terms and you have to know examples of disease states, or what's normal and what's not normal. All right. So just kind of keep that in the back of your mind as we work through this. Okay. So the first on top of page 21 there, we're in letter B, where it says normal chest X-ray or radiograph. These are some descriptions of what you should see on a normal X-ray. So here again, both hemidiaphragms should be rounded, and you can kind of see that on our illustration here in this first slide. Okay, those are both rounded. The right hemidiaphragm is a little bit higher than the left. And then the right hemidiaphragm is at the level of the sixth anterior rib. And again, the reason this right side is higher than the left is because the liver, is the thing that's kind of encroaching upon it there. Number 4, trachea is, of course, midline, and is also, there's bilateral radiolucence, in the lungs. So basically, you can kind of see structures in front as well as some structures from behind. You can see some ribs coming back around here, okay, on the back side. And there should be nice, sharp costophrenic angles right here, okay, on both sides. All right. And again, this is The lateral, of course, is a little bit more dense because of the number of structures it has to go through shooting from the side. We've given you both illustrations of how that's supposed to look. The next thing that you've got to be familiar with are terms that describe, or phrases that describe, the quality of the X-ray, okay? And so under letter C there, highlight number 1, the heads of the clavicles should be level, which if I go back over here, you can kind of see that both of these clavicles right here are pretty much in line with one another so that the film is not rotated. Number 2, penetration. It should be a well-penetrated X-ray, one in which the vertebrae are just visible behind the heart. And so you can see the vertebrae behind the heart in this particular illustration here. And then the bottom of page 21, number 3, the space between the vertebrae should be equal, visible, and distinct. And so you should be able to pick out each individual vertebrae, you know, here in the center of the film, right? And so those are all nice sounding words: equal, visible, and distinct. Landmarks, number 22, these are some terms that you need to be familiar with here as far as the anatomical landmarks. Number 1, the trachea. Again, that's going to be seen as a dark area midline. Number 2, the costophrenic angles, which we've already talked about down here. If they are blunted or obscured where you can't see a nice sharp angle, then that of course is going to indicate that is probably a pleural effusion. Diaphragms, if you see diaphragms where the chest looks really overinflated, that could be an indication of COPD, number 5 there. Number 6, vascular markings, which are all of these structures right around the heart and the hilar area. If you see those become more prominent, then of course that could indicate an increase CHF. Number 7, the diameter of the heart. Okay. If the size becomes really big, takes up much more of the chest, then of course that could indicate you've got some sort of heart issue going on there. Keep in mind, of course, that the heart can actually be shifted from one side to the other depending upon if you've got pathology that's taking place on either side of the chest. Number 8, the soft tissue in the neck above and so forth. Sometimes there may be sub-Q in those areas where it looks kind of like bubbles. Number 9, if you see the ribs that are close together, then that could indicate you may have atelectasis in that lung. If the ribs are more horizontal or straight across, then that usually means that you've got air trapping. And again, if you've got air trapping, you're going to see the lung hyperinflated and the domes of the diaphragm are going to be more flattened. Top of page 23, positions and projections. Number 1, the AP projection. Remember, that's going to be shooting from the anterior to the posterior, so from front to back. And that's typically done, of course, at patients that are, in the bed, like in ICU and that type of thing. Whereas number 2, the PA projection, the X-rays usually travel from the back or shot from the back posterior to the anterior. All right, and that's usually done when they have the patient down in outpatient area as far as X-ray. Highlight number 5, the lateral decubitus. We'll talk about this, and we'll show you a picture of this here a little bit later. But the lateral decubitus position, you've got the patient laying on their affected side, and this is letter B, highlight letter B. It's valuable for detecting small pleural effusions. Drop down the middle of page 23, letter F, the position of the endotracheal tube or tubes. Highlight number 1, the tube should be positioned A, below the vocal cords, and B, approximately 2 to 6 centimeters above the carina. Now that 2 to 6 range, again, should prompt you to think back to normal CVP, right? Normal CV is 2 to 6 millimeters of mercury, Well, that same range, 2 to 6, you can kind of use that as a memory tool to help you remember about where the length of the tube should be above the carina, 2 to 6 centimeters above the carina. Letter C is using anatomical landmarks. They may give you that also on the test. And so the anatomical landmarks for the tube being in the proper position are letter C at the level of the aortic knob or aortic arch. All right. Letter G, evidence of an endotracheal tracheostomy tube cuff hyperinflation. Highlight that. You can kind of read through it. Letter H, position of a pacemaker, catheters, and other tubes. Drop down to number 3 at the bottom of page 23. Highlight number 3. The central venous catheters are inserted through the subclavian or jugular vein and should rest in the superior vena cava or at the right atrium of the heart. Number 4, chest tubes should be located in the pleural space surrounding the lung. And number 5, the nasogastric tubes and feeding tubes should be positioned in the stomach about, again, 2 to 6 centimeters above the diaphragm. So here again, that 2 to 6 is a good memory tool to remember because it helps you with your endotracheal tube position, but it also helps you with your nasogastric tube position as well. All right. Top of page 24, lateral neck x-ray, drop down to number 2. Both conditions that are caused for localized swelling in tissue and obstruction, these two conditions in which a lateral neck x-ray would be useful would be A, croup, which is also referred to as laryngotracheal bronchitis. Remember that in laryngotracheal bronchitis, that basically what you have is a tracheal narrowing with subglottic swelling. So that means swelling below the glottis. And it typically gives one of these 4 patterns. All right, all 4 of these patterns mean the same thing. It's just different terms depending upon which part of the country you're from. It could be referred to as a steeple sign. It could be referred to as a picket fence sign. It could be referred to as a pencil point sign, or it could be referred to as an hourglass sign. Those are all descriptions that would describe croup or a subglottic swelling. Letter B, this is a supraglottic narrowing. This is above the glottis. And typically what you see here is letter A. It's known as the thumb sign. So basically the epiglottis swells or gets inflamed. And it is a structure that looks like a thumb on a lateral neck. And so whenever you see it, it just, it ends up looking like a thumb whenever it's swollen. Excuse me. Middle of the page 24, highlight letter J, extrapulmonary air. That is defined as air outside of the lungs. And again, examples of that could be letter A under number 2 there, pneumothorax, and then letter B, the pneumoperitoneum, which is, of course, in the abdominal area. The peritoneum's in the abdominal area. Letter K, presence of foreign bodies. Highlight number 1. Examine the airways for any aspirated or foreign objects. And number 3, remember that the majority of aspirated objects are radiolucent and you can't see them on an X-ray. That brings us over to page 25. And we have 2 boxes. And remember what we said about a box? A box means it's important. So these are terms that you're going to need to walk your way through and look at these to verify that you know what they mean. Okay, we're not going to spend a whole lot of time on them because, like I said, they're pretty self-explanatory. But you need to look down through each of these terms at the top of page 25 on the first box: radiolucent, radiodense, opacity, infiltrate, consolidation, hyperlucency, vascular markings, diffuse, and opaque. We've given you a description of what that means, and then again, the diagnosis that is associated with it. And then we kind of flip that around. Down at the bottom, we have a listing of diseases or diagnosis on the left-hand side. And then we give you the terminology that could be associated with those, and also a description. And then we tell you how you would treat it. All right. So this is a very important page when it comes to x-rays, knowing these terms, what it means, what the term, which disease the term is associated with, and then potentially what would you do to treat that problem. Okay. Now, there are two areas that I want to point your attention to in addition to just the box. Drop down to number 4 there where it says pleural effusion. And in the second column there, the terminology column, I want you to highlight the second bullet there where it says basilar infiltrates with a meniscus. So the meniscus, whoops, I got ahead of myself, sorry. Meniscus, I'll show you what that is here in just a little bit when we show you a picture of this on a pleural effusion on an actual x-ray. But that term meniscus is something that you need to be familiar with. And then drop down to number 6, pulmonary embolus. The term peripheral wedge-shaped infiltrate, anytime you see that on the test, peripheral wedge-shaped infiltrate, you need to associate that with a pulmonary embolus. All right. I know you don't typically hear that very much maybe clinically, but on the test, that's just a little hint when they give you that on an x-ray of what they're looking for. All right, so I remember those two terms, meniscus and peripheral wedge-shaped infiltrate, and then the diseases that they're associated with. All right, that brings us over to our pictures. Again, each of these pictures are potential disease states that may be shown on the test as a picture. That doesn't necessarily mean that our picture is the one that's going to be on the test, but you need to know the characteristics of the image so that you know what you're looking at and associate with it on the test. So this first one here, top of page 26, is an example of the pneumothorax. And again, the way that you know it's a pneumo is because you can see there is dark air or darkness on this side over here when you compare it to this side, and you can see these blood vessels that are going all the way out to the periphery. You do not see that over here. So this is all air in this space right here, okay? The lung is actually right down here, okay? That's lung right there. So that's a huge pneumothorax. The next one is ARDS, and again, if they give you this picture, and typically they're going to give you other information about the patient so that you'd be able to say it was ARDS, because I mean, this could be just a terrible pneumonia too. But again, when you see just a bad bilateral x-ray and infiltrates your out, and lines going everywhere, that's usually an indication this is ARDS. Okay, top of page 27, pleural effusion. Here we've talked about this, and again, the effusion in this x-ray is on this side because there is no nice sharp costophrenic angle. You can see there is a nice sharp costophrenic angle over here, but this is not really a sharp cost because it should drop down. It should be an arch in here, right? And there's no arch, just like there's an arch right here. All right. So this is a fluid level. So another way of verifying that this is an effusion is, of course, looking at the lateral decubitus, but we'll get to that here in just a second. Here's that about the meniscus. If you forgot what a meniscus is, this is, again, whenever you put water like in a test tube, you can kind of see how it kind of curls up against the edges. That's what the meniscus is. So that's a concave meniscus. And if it was mercury, it kind of goes the other way. But this is the thing I wanted to kind of you to associate that word meniscus with as far as the pleural effusion. And then this is an example of the lateral decubitus. So this is a very helpful x-ray in diagnosing a pleural effusion. So here we see we've got the effusion here. It's pretty obvious looking at this, that's what's going on. But if they wanted to verify it, laying the patient on their side, we can see that this shape has changed over here in this lung, and now the fluid is actually up against the gravity dependent portion of the lung, the side that's down. So this was free moving fluid. By doing this test, we see that the fluid moved, and that would be definitely a confirmation that this is a pleural effusion. Bottom of page 27, right main stem intubation. Here again, we can see the endotracheal tube coming down. This is a overinflated right lung, and this one here is atelectatic because of the tube being in the wrong place. It should be 2 to 6 centimeters above the carina, so it should be somewhere right up here close to midclavicular line or at the aortic arch or knob. Page 28, other imaging procedures, computer tomography. Again, they're not going to have you do an interpretation of these, but they will ask you a question that may relate to number 4. So highlight number 4 on page 28, A28. You may need to get a spiral CT scan with contrast dye to diagnose a pulmonary embolus. That's an important thing to remember. That's how you can verify that you've got a pulmonary embolus, is with the CT scan with contrast dye. Top of page 29, they may give you a picture of a pneumo on a CT, and that's pretty easy to pick out because all this black area here, there's nothing in there but air, so that's all pneumo. And here's, of course, is the lung that is collapsed down compared to the lung on this side over here on the right side. All right. Also, there may be some other imaging procedures that they may refer to, just so that you, and most of us know what they are. You don't need to know a lot of details about them. On page 29, letter B, the MRI. Highlight number 3, it has the ability to determine precise position of tumors and soft tissue abnormalities and the involving surrounding structures. And then highlight number 7, this is a safety issue that you need to be familiar with if you're around MRIs, is that you need to make sure that if you're providing oxygen with a cylinder, that it is a aluminum cylinder and not a steel cylinder. So again, that can mess your day up. I don't know if you've seen the YouTube videos of a watermelon in an MRI with a steel cylinder, but you can imagine there wasn't much of the watermelon left when they turned the MRI on. All right, let's see here. Top of page 30, the ventilation perfusion scan, highlight that one, drop down and highlight number 3. Normal ventilation scan with abnormal perfusion scan can indicate a pulmonary embolism. So know that that is associated with the pulmonary embolism. Letter D, the only thing I would like for you to note beside it is to not pick it. Do not pick barium swallow unless you've got number 4, letter B, dysphagia, which is difficulty in swallowing. But most of the time they may use that barium swallow as a distractor for an X-ray procedure that may need to be done on somebody. Letter E, definitely don't pick it, the PET scan. Drop down to letter F at the bottom of page 30, the bronchoscopy or bronchogram. Number 2, it outlines the airways and helps you to identify whether or not you've got bronchiectasis. Then number 3, another thing that can confirm your bronchiectasis diagnosis is that the sputum does a very, very unusual thing. You may want to make a note of this next to number 3. The sputum separates out into 3 distinct layers. And yes, it does smell foul. Foul smelling sputum with 3 distinct layers, that is classic diagnosis for bronchiectasis. All right. Top of page 31, special diagnostic studies. Highlight letter E, the EEG. Under letter A there, drop down to number 3 and highlight the letter E. It's used in evaluation of sleep disorders. Letter B, pulmonary angiography. Number 1, this is the number 3 way that you can identify a pulmonary embolism, but is the one that has the greatest risk, and so this is the one that you choose last. So you may want to make a note someplace around the on this page that pulmonary E or pulmonary embolism, PE, is diagnosed by 1, CT scan, 2, VQ scan, 3, pulmonary angiography, and in that order. So 1, CT scan, 2, VQ scan, 3, pulmonary angiography. And the CT scan has the least amount of side effects or risk. The VQ scan has the next least amount, and then of course the pulmonary angiography has the highest. So that's the reason why those are prioritized in that fashion. Highlight letter C, the echocardiogram. We've already talked about that. Under number 3 there, letter E, highlight it, abnormal heart sounds. Anytime you hear abnormal heart sounds diagnosed or referred to in the on the test, you need to be thinking, get an echo, get an echo. All right. Letter D, cardiac catheterization. Most of us know what that is. Not a lot of questions they're going to ask you about that. Just be familiar with what it is. All right. That brings us over to, whoa, got ahead of myself. Sorry. Letter E, intracranial pressure monitoring, or ICP. Some important things to remember in this area. Number 2, I like that one. The normal ICP value is about 5 to 10. And then number 3, recommend initiating treatment if the ICP gets greater than 20. All right. Now, I think I messed up here. I forgot to tell you about my favorite number. I want you to circle that number there, number 20. All right. And then right next to it, put John's favorite number. So anytime on this test, if I can't remember what something's normal is or whatever, I just pick the number 20 and just move on. All right. It may be right, it may be wrong, but there's a lot of not obscure values, but there's some common values that we talk about throughout the seminar where 20 will basically hit the number that you're looking for. So that's why I say remember. And this ICP thing is one of the ones that I encourage people to remember. Because if you have an ICP that's greater than 20, then that's when you need to recommend treatment. And that's what it's saying there under number 3. So recommending or initiating treatment if your ICP gets greater than John's number, which is 20. Highlight number 4, therapy that can reduce the ICP. Letter A, you could do hyperventilation. And if you're doing hyperventilation, your target CO2 is going to be between 25 and 30. Highlight number 1, it only temporarily decreases the ICP. So remember, it's only a temporary thing. It's not something that you typically do. Most of the time they're not going to have you do that in a real live clinical situation, but they may ask you this question on the test simply because they want to know if you realize that causing hyperventilation can actually cause vasoconstriction in the brain, which would lower the intracranial pressure. All right. Letter B, you want to lower jugular venous pressure. Again, this also can help minimize intracranial pressure. Highlight number 2, the way you do that is by letter A, keep the head of bed elevated greater than 30 degrees. Letter B, you want to minimize straining, retching, and coughing. And you do that by sedating the patient. All right. The third thing there is you want to minimize PEEP. Remember, PEEP can cause an increase in intracranial pressure. So if you're having difficulty managing your intracranial pressure, you really need to watch your PEEP levels and don't overdo it with the PEEP. Letter C, sedation and analgesia. That can help you get your ICP down. And then the big one here is to remember is letter D. If you have number 1 there, mannitol is the drug that's used for managing ICP. And it's basically a diuretic, but it's a diuretic that's used for treating an increase in intracranial pressure greater than 20. Okay, that's the key thing to remember. ICP's got to be greater than 20 before I start to treat it. All right. Number 5, the cerebral perfusion pressure. This is an important number to evaluate to determine whether or not you actually have blood flowing through the brain which is also used to determine brain death. But the main thing you need to understand is that it's used for determining brain death. It's not the only way. It's not the definitive. Well, take that back. It is the definitive way for determining brain death as opposed to a flat EEG. All right. If you got a flat EEG, then they're going to do the cerebral perfusion pressure, looking at the mean arterial pressure minus the ICP. And if it is not at least 70, then that means that the brain is not getting blood flow to it. And so therefore it has no survivability. And that's what's used for determining removal from life support at that point. Top of page 33 is the exhaled gas analysis. Highlight number 1 there, the exhaled nitric oxide or FeNO test. Highlight letter B under number 1. It's used to monitor the patient's response to anti-inflammatory or steroid treatment. Letter C, it's useful for monitoring patients with asthma, cystic fibrosis, and COPD. And then letter D is important to remember. A decrease in FeNO suggests a decrease in airway inflammation. So basically what we're saying here is if they have a reduction in FeNO, then that means that the steroid is working. If they don't have a reduction in FeNO, that means the steroid is not working. All right. Now, you don't need to remember the normal value for that because we've not included that in your notes there. But on the test, what they may say is you note that this patient has a reduction in FeNO. And as soon as you hear a decrease in FeNO, then you need to know, all right, steroids are working. That's a good thing. Okay. Number 2 on page 33, exhale carbon monoxide. We've given you a box here. Again, this is something that is typically used for monitoring patients and their smoking cessation program. And the box there, the thing I want you to highlight is the last row in the box where it says non-smokers. That needs to be less than 7 and certainly under 10. So if you've got a patient who you're doing smoking cessation with and you're trying to verify that they are indeed not smoking, you do this test on them, they exhale into the device, and if it's less than 7, then that means that they are complying with your program, your smoking cessation program. However, if it's over 7 or over 10, then they're definitely not complying. They're smoking in between visits, okay? Letter C, the exhaled CO levels can also be elevated in patients with obstructive sleep apnea, so that's something to remember. Top of page 34, lab testing. Oh, I forgot. Here's my, I think most everybody recognizes who this is. That's you. That's usually what happens. We're always in the way when they come in to do the x-rays, right? And so we have to kind of leave the room and all that kind of stuff anyway. So we're always where we're needed and when we're needed. I think that's probably a pretty accurate statement. All right, so top of page 34, let's talk about lab testing. Letter A, the CBC. What are things that we need to know in the CBC? Well, the first thing we need to know is the red blood cell count. So highlight number 1 and then drop down and highlight letter B. The normal value for that is 4 to 6 millions per meter squared. Okay. The next CBC value is hemoglobin, number 2 there. Highlight letter B there also. The normal value for it is 12 to 16. And then number 3, the hematocrit. The normal value for it is 40 to 50%. Right. And then there's 2 bullet points that are not in your notes there that I would like for maybe just to write off to the left-hand side there, top of page 34. You need to remember that all 3 of these measurements, the RBC, the hemoglobin, and hematocrit, they're all related to oxygenation, and they all move in the same direction. So in other words, if your red blood cell count starts to take a dive, that means your hemoglobin and your hematocrit is going to decrease also. right? And vice versa. So they're all related to oxygenation and they all move in the same direction. Now, the other thing I want you to remember is it may be difficult for some of you to remember the normal values for these. And if that's the case, I've got a little memory tool for you. If you already know these and you don't have a problem memorizing them, then don't worry about this. This is just for those of us who need a memory tool to help remember. So here's the memory tool. It's 5 times 3 times 3. Okay. And so write that down. This is not in your book. And so basically the 5, oops, let me back up. The 5 in this 5 times 3 times 3, this represents the 5 is the normal value for a red blood cell. So again, the normal range we said was between 4 to 6. And the number that's between 4 and 6 is what? Yeah, 5. So we just take that 5. So that first number right there tells you what the normal range is, or the value of a red blood cell count that's within normal range. So RBC should be around 5. Okay. And then if you take that 5 and multiply it times 3, then what that does for you is that brings you up here to 15. And 15 is right in the middle between the 12 to 16 range of the hemoglobin range. Okay, so 5 times 3 is 15. That'll give you a normal range for hemoglobin. And then if you take that 15 and multiply it times 3 again, that's going to give you 45. And 45, as you can see here, that's the middle range of the hematocrit here, 40 to 50%, right? So it's just a little memory tool to kind of help you remember the normal range. So anytime I hear CBC, I'm always thinking 5 times 3 times 3. That's what I'm thinking to help me remember what the normal values are those supposed to be, okay? That brings us over to middle of the page 34, white blood cell counts. I want you to highlight letter B under number 4 there. The normal range is 5 to 10,000. Letter C, if we have an increase in white count, that is also referred to as leukocytosis. And it means that we've got a bacterial infection and that we need to recommend antibiotics. All right. Now, which antibiotic are we going to recommend? Well, here's a little saying for you. Pick something that ends in cillin or myosin. Pick something that ends in cillin or myosin. Those are always good drugs to choose as far as identifying antibiotics. Okay, those two suffixes, I guess it is, right? Yeah, suffixes. Letter D, a decreased white count is referred to as leukopenia, so make sure you're familiar with that term. Leukopenia means a reduction in white count, and that usually indicates a viral infection. And so that's when we would recommend antivirals. Drop down to number 5, types of white blood cells. The main one I want you to highlight there is letter B, the eosinophils. And those are associated with an increase in allergic reaction, or they increase with allergic reaction. All right. Top of page 35, electrolytes, normals for electrolytes. Highlight number 1, those are the electrolytes you're typically going to see on the test. And remember, if those are out of whack, the person is going to be described as having what? That's right, general malaise. General malaise is that just kind of weak, whiny, complaining feeling, right? And so we need to fix the electrolytes that are out of balance in order to help the patient feel better. So drop down to number 2 there, the potassium. Normal potassium, letter B there, their normal range is 3.5 to 4.5. Drop down to number 3 there, the normal range for sodium, letter B, or letter A actually, is 135 to 145. And then for chloride, the normal range for that is 90 to 100. All right, those are ones I want you to remember there. And then if you have a hard time remembering these ranges, there's a little memory tool that may help you. Here again, just use it if you find it helpful. If it confuses you or makes you, don't use it. This is just to help those who may need some help remembering these. So the thing I think about when I think about electrolytes, I think about the CO2 for these first two, the sodium and potassium, because basically the normal range for CO2 is 35 to 45. And you can see up here that we've got those same numbers that are used, the 3, 5, and the 4, 5 up here. Only difference is you've got the little decimal in between them. And remember, potassium, there's a very small amount. We don't need very much potassium. So that's why these numbers are small. As opposed to sodium, that's the largest cation by volume in the body. And so therefore, what we would do here, again, there's the numbers 35 and 45, same range as CO2. You just put a 1 in front of them. Okay, and that may be something that may help you remember what the ranges are. For the chloride, this is not exact. I mean, they used to give us a range of 80 to 100, so it fit perfectly. But now they've changed the range, I think, according to our text, to represent a range of 90 to 100. So they've kind of tightened it up a little bit. But that's still pretty, pretty normal range for a PO2, 90 to 100. Okay. Oops, and let's see, down at the bottom there, number 5, the bicarbonate, drop down to letter C, the normal range for that is 22 to 26. All right, so we're just kind of working through this stuff, highlighting stuff that's important to know. If what you're hearing is information like, oh yeah, I've heard that, I know that, I mean, that's good, all right? But if what you're hearing is, don't remember that, never heard that, then that just means you're going to have more work to do whenever you go through this process and preparing for the test. All right. So again, that's always going to depend upon the individual as far as how much they've learned and how much they retained as they go through. So what we're trying to do here is, again, just identify those important lab values and their normal values so that you can interpret them and know what they would indicate. Top of page 36. Number 8, the sputum analysis. Letter A, the way we describe, one of the things we describe is how much does a person bring up. And I want you to highlight the word copious at the end of the sentence there. That just means a huge amount. That's more than a large, okay? The other thing, letter B there, consistency. Thick, thin, or tenacious. Remember that word tenacious? That's the type of mucus that whenever the patient spits it into a sputum cup, it just kind of sits there on the side of the cup. It just doesn't move. That's what tenacious is, right? Letter C, the color. Number 1, clear is normal. And just remember, if it's not clear, then it's not normal. Don't get caught up in some of the other things. Just make sure you know that clear is normal. And again, if they tell you that the sputum is yellow or green or whatever, just know that it's not normal. Something's wrong. There's an infection probably present. Or again, if it's bright red, probably not an infection, but probably blood. Pink frothy, of course, is pulmonary edema. But the main thing to remember is normal sputum is supposed to be clear, right? Letter D, the sputum culture. This can be used to identify bacteria that's present, and it can take 48 to 72 hours to get these results back. Letter E, the sensitivity. This will identify the antibiotics that are going to kill the bacteria. And that again will also take 48 to 72 hours to get back. And then highlight letter F, the gram stain. This is going to identify whether the bacteria are either gram positive or gram negative. And highlight this next statement, takes 1 hour. Takes 1 hour. So if on the test they ask you that we need to rapidly assess the sputum sample, what type of assessment or test would be rapid? That would be the gram stain. The culture and the sensitivity, they take 48 to 72 hours to get back. All right. So that's the take-home message from those 4 points there. Letter G, the acid-fast stain, identifies the Mycobacterium tuberculosis, or TB. And that's how we do that. Drop down to number 10 on page 36, coagulation studies. Now, here's the thing. They're not going to ask you a ton of questions about coagulation studies, you don't need to know normal values and things like that, but you need to recognize what are the coagulation studies and when you would get them. Okay? And so basically, letter B, you want to highlight that one because that gives you the indications for coagulation studies. So be familiar with it. Highlight letter C, clotting time. That's an example of a coagulation study. Letter D, platelet count, is an example of a coagulation study. Letter E, activated partial thromboplastin time, or APTT. That's an example of a coagulation study. And then letter F, the prothrombin time, or PT. So again, you don't need to know what the normal values are for this test, just like you don't need to know what the normal drug dosage range is for many of the drugs. You just have to know what the test is and when would you use it. Okay, and so there they are. Letter B is when you use it, and then C, D, E, and F are examples of the tests, the coagulation study tests. Right, that brings us over the top of page 37, cardiac enzymes and biomarkers. Under number 12 there, the top of page 37, highlight letter A, troponin, and then drop down and highlight number 2, patients who suffered a myocardial infarction would have elevated troponin levels. And then highlight number 3, troponin levels greater than 0.1 place the patient at risk for death from an MI. That's important to remember. Then highlight letter B, brain natriuretic peptide, or BNP. Highlight number 2, the normal value for that is less than 100. Okay. Highlight number 3, it's a measurement of serum BP is helpful in determining patient's symptoms as a result of CHF or some other condition such as COPD. So it kind of helps you differential diagnose in those two situations. Number 4, the elevated levels can indicate CHF. And so if you've got a level greater than 300, you need to be thinking CHF. And if we got CHF, then what are we going to give them? We're going to give them, that's right, furosemide. How much are we going to give them? However much it takes to get the CVP down, right? Below 6. Okay. Letter C, skin testing. Highlight number 1, the tuberculin skin test is also referred to as the Manitou test. Guess which probably term they're going to use on the exam? Yeah, Manitou. They probably won't say TB skin test, because if they say that, then you'll know what they're talking about. Again, some people get upset and they say, well, why don't they just say what everybody says? Well, because they're trying to see if you can, talk respiratory therapy. That's what they're trying to figure out. Because if you understand those terms, then they know, then when you're talking to physicians and nurses about some of these situations, then, okay, you're not going to be in the dark about what they're talking about. All right. They want to make sure that we're working together as a team and that we're all can speak the same language. All right. Okay. That brings us over to page 38. Let's talk about the electrocardiogram, or the ECG. So the first thing we'll talk about is some of the equipment. Letter A there, the first piece of equipment is the oscilloscope. This is the bedside monitor, of course, as you can see. So there's lots of information besides just the ECG tracing that you can get from the bedside monitor. But this is at the bedside. Highlight number 2, the electrocardiograph. This is the 12-lead ECG machine. All right. We'll talk more about that here in a minute. Number 3, the bottom of page 38, is the Holter monitor, and this is where they put this on someone and send them home and then monitor their rhythm over a period of time to see if maybe they can associate a rhythm with something else that's going on, either an activity or an event. And then from that, they can diagnose maybe what's going on with the heart and figure out a solution for that. On page 39, top of the page 39, electrophysiology of the heart, what I would like for you to write at the top of that page is the word skip. Skip. We're going to skip that entire page. And that's not to say that this information is not important. It's just not, they're not going to ask you questions about this information on the test. This is background information that you got to understand in order to interpret an ECG tracing. And the MBRC is going to focus most of its questions on information that you're going to assess on the patient, and then you make a decision about what needs to be done. All right. So we won't have to worry about that. Page 40, a couple things just to note here on page 40. The top of page 40, highlight letter number 6, axis letter A. You need to know that the axis of an ECG measures the net direction of all electricity through the heart during the contraction. And then highlight letter C, the normal axis is in the direction of down and to the left, down and to the left. And so if you look here on the illustration, remember from your electrophysiology that the initial impulse originates in the SA node, then it goes down to the AV node after it contracts all the atria. And then after the AV node, it goes through the bundle of His and right and left bundle branch down and to the left. All right, so that's where that down and to the left comes from. So this is the natural flow for electricity through the heart. And that's what the axis represents. What is the normal flow of electricity through the heart? So if they say that the axis is deviated, that means the deviation means that it's not going down and to the left. And so something's wrong with electrical activity of the heart. Okay. Top of page 41, ECG electrodes and leads. Make sure you know the difference between the two. Highlight number 2, an electrode is the sticker. That's the thing that you stick onto the chest and the location of the leads. And then number 3, the lead is the view that you're looking at the heart. And so if you look at the bottom of the page there, we've given you this illustration to show you that, okay, you've got a lead 1, which basically you can see the arrow here is looking from this side, from the right side to the left side on the top here. And then you've got another lead here on the left arm, lead 3, that goes from this area down here. So that's looking from this direction. And then you've got a lead 2 that's looking from the right arm down to the left leg. Okay. Now, what I would suggest you do is you highlight this lead 2. All right. And the reason I want you to highlight lead 2 on this page is because lead 2 represents the normal flow of electrical current through the heart. Remember, we said the axis of the heart should be down and to the left. And so this is the one that most accurately represents that axis, down and to the left. So that's the one we want to monitor a patient. If they ever ask you on the test, what lead would you like to monitor the patient? You want to pick lead 2. All right, pick lead 2. All right, top of page 42, we've got the chest leads. The main thing to remember here, we've given you a box that kind of tells you, you know, where they're supposed to be placed. Okay. And the easiest way for me to remember it, and I'm sure you remember also if you went through an ECG rotation, is you're going to place one lead on either side of the sternum about mid-nipple line. Okay. And then you're going to drop down below this plane here and put one right there. That's also mid-nipple line. I guess that's mid-nipple line that way. Okay. And then you're going to put one mid-axillary line. Right. And then after you've done that, you'll come back and in between 4 and 6 here, you're going to put 5. And then between 4 and 2, you'll put 3. So that's basically how you position the chest leads. So just be where the location of those chest leads are. Let's see. Tom, did y'all lose me for a minute?
Nope, I'm here.
Okay, I just saw this little thing flash up on the dashboard. It said audio restored. So I didn't know if we were getting some kind
That
of,
might have been your audio, but we've been hearing you.
okay, all right, that's good then. Great, thanks. All right, so top of page 43. We're going to look at interpretation and management of ECGs. Again, highlight number 1 at the top there, letter A, the normal heart rate should be between 60 to 100. And then under number 2, estimating the heart rate. What I'm going to do is I'm going to kind of read through letters B, C, and D for you, and then I will show you how that works on an actual ECG tracing, okay, for estimating heart rate. It's easier to show you than it is to necessarily understand what it's telling you in the language there. At least for me, it is anyway. Okay, so under number 2, estimating heart rate, highlight letter B, and it says here, if two of the R waves are between 3 and 5 large boxes, then the rate is normal, which is 60 to 100. Letter C, if the 2 R waves are closer than 3 boxes, then the rate is greater than 100. And then letter D, if the 2 R waves are wider than 5 boxes, large boxes, then the rate is less than 60, which means you have bradycardia. So if we take those 2 terms, or those 3 terms, and give you an example here, in this particular ECG tracing we see here is the R wave, here's the R wave, and we've got 1 big box, 2 big boxes, 3 big boxes, 4 big boxes. So we've got 4 boxes between the 2 R waves. And so because the number 4 is between 3 and 5 large boxes, that means that the rate on this strip would be considered normal, a normal heart rate of 60 to 100, okay? Now, as we go through some of these other examples, I'll kind of show you what I'm talking about as the rate changes, and you'll see how that works. So here again, this is a normal sinus rhythm, bottom of page 43. The thing that I want you to remember about this is, remember, it's got all the parts. So there's your P wave, QRS, and your T wave. The distance between the QRS or the QR waves or QRS complexes is the same. Okay, so it's got all its parts. It's got a normal rhythm. The rate is normal because there are a half, 1, 2, 3, and another half. So there's 4 boxes. So again, the rate, the R interval there is within 3 to 5 large boxes. Okay. So that would be considered to be a normal sinus rhythm. Now, there's only one thing. If there's any other symptoms, you would treat that. But here's the other thing I want to remind you is that if you saw this rhythm and they said that the patient was unconscious and pulseless, then you could not interpret this as a normal sinus rhythm. So anytime you see a normal sinus rhythm, pay close attention to other information on the test that they may be sharing with you about their pulse. If they say that there's a pulse that's steady and 60 to 100 beats per minute, then this would be considered a normal sinus. But if they give you this picture, which most people, when they see that, they say, oh, that's normal sinus. But then if they told you that the patient's unconscious and has no pulse, then that's not the interpretation for the ECG. So just a word of caution, when you see something that looks normal, make sure they're not giving you any other piece of information on the physical findings that would indicate there's a problem, all right, especially with your life functions, all right?
John?
Yes, go ahead.
Yeah, if you would just want to repeat for a moment the part about estimating heart rate by counting the number of boxes.
Okay, thank you. All right, so what I'm going to do is as I go through each one of these illustrations, I'm going to show you how to do that. So every time we put one up here, we're going to practice that. And hopefully that'll answer the questions before we get to the end. Okay? Because I know I went through that kind of quick, but I know that I was going to be doing it every time. So here again, here's the the R wave, R wave. We need to measure how many big boxes are between them. We've got a half of one right here, okay? There's a full box there, full box there, full box there, and a half of one there. So that's about 4 boxes. which means that that is between 3 and 5 boxes, that's normal. So as long as the number of boxes is between 3 and 5, that's considered a normal rate. All right. So we do this next one here. This is a sinus arrhythmia, and you can obviously see in this one that the number of boxes is greater, 1, 2, 3, 4, 5 here, and 1, 2, 3, 4. So we got a variation in rate here. And that's the tip off that, hey, something's not right, because the number of boxes between each of the the R waves should be the same. So in this case, that's what makes it a sinus arrhythmia. There's something going on with the pacemaker that's delaying or whatever, the start of the beat. So in this one, all of these boxes in between are considered normal, so that's not a problem with the sinus part. So the rate's not an issue here. But again, there's something that's not normal about the entire ECG tracing because of the gaps or the distances between these two R waves, and there's less distance between these two R waves. And so you can see there that what we've said is, in this case, if it's diagnosed as a sinus arrhythmia, what you're going to do is you're not going to do really anything except treat any other symptoms. If they're having shortness of breath, you put them on some oxygen. Okay. All right. Oh, that's not supposed to be there. That's supposed to be on the other page. So just disregard that. I'll have to fix that later. All right. So sinus tachycardia. How do we know this is sinus tachycardia, fast heart rate? Well, first off, when we look at and we see the number of big boxes, it looks like there's about 1.5 between this R wave and this R wave, and they're about the same distance between all the rest of them. That's less than 3 boxes, so that's a fast heart rate. Fast means tachycardia, all right? But again, we've got all of the ECG structures, the P wave, the QRS, and the T wave. We have all of those all the way across. We just have a fast rate is what we have. So that's why it's referred to as a sinus tachycardia. And you can see there on page 44, the treatment for that is going to be oxygen. All right, that's the first thing we're going to do. That's first. I mean, anytime the heart rate goes up, that's one of the first things that can cause it to go up is hypoxemia. So we'll give them some oxygen. All right. Once again, on this one, this is sinus bradycardia. And the reason it's bradycardia is because look at the distance between this R wave and this R wave. There is quite a full box, but 1, 2, 3, 4, 5. And again, this little bit with this would be basically 6 boxes between these two R waves. So because the distance is greater than 6 boxes, that means that that is a slow heart rate. It's less than 60, which that would constitute bradycardia. All right. Again, it's sinus bradycardia because you've got all the parts. You got a P wave, a QRS, and a T wave. It's just that the rate is slow. All right. And so here again, we're going to treat this with oxygen and atropine. The next one here is a new one that they've added to the test. This is atrial flutter, but most of you already know what this is because you've had ACLS. And again, you see that we're not seeing all the normal parts here. So we've got some of the parts, the QRS we can identify, but what's all this stuff down here? That just looks like a lot of weird looking P waves or something. And that's basically what it is. And so basically, this is the standard sawtooth pattern, what they refer to as a sawtooth pattern for atrial flutter. And basically what that means is that we need to do something to slow the atrial rate down. And so basically the treatment for that is digoxin, beta blockers, calcium channel blockers. Those are all things to slow heart rate down. Okay. So you notice we didn't get too wrapped up in the rate of the QRS complexes. It's more of the rate of these atrial contractions here that are kind of giving us concern. Top of page 45, atrial fibrillation. This is one that's always interesting. here again, as we look at it, we can tell that doesn't have all the parts. We don't see the P wave, QRS, and the T wave like we normally would. There's a lot of this extra wave action in between the QRS complexes, and then there's variability between the distances of the QRS complexes. And so that's just classic, atrial fibrillation. And so again, atrial fibrillation means that the atria are just contracting so unchaotically that they're not really generating a good filling of the ventricles, and so therefore your cardiac output could be compromised, and therefore the slow blood flow moving into the ventricles could be subjected to clots formation, and that's why they typically are going to put people on the things to slow the rate, but also anticoagulants or antithrombolytics because of clot formation with this particular type of arrhythmia. All right, that brings.
John,
Yes,
can you go back to atrial flutter and go over that one again briefly?
sure can. Sure can. So flutter, because this is oftentimes where people kind of get confused between flutter and fib. And what I tell people about flutter is that it's much more uniform than atrial fib is. Okay. And so again, this right here is the sawtooth pattern that I'm kind of riding along right here. This is with my arrow. That's the sawtooth pattern. All right. So it looks like the teeth on a saw. And so basically what's happening is the atria are contracting at a very fast rate. All right. And again, there's actually several contractions of the atria for each one contraction of the ventricle. So the heart is not in sync. Remember that the atria under normal conditions to contract one time for every contraction of the ventricles. And in this case, we've got multiple contractions between each ventricular contraction. So that is definitely abnormal. All right. Now you come back over here to fibrillation. Again, fibrillation again is indicating chaotic contractions, and the chaotic contractions are in between the QRS complexes. Okay. Treatment for this one is basically the same as atrial flutter, except you're adding the anticoagulant. All right, that brings us down. So if you're having difficulty remembering those or don't know those, again, I would refer you back to your ACLS information. What we're trying to identify for you on the study guide is that this is something that you will have to know, be able to recognize, and you will also have to be able to give some treatment for it. So that's why we put, the strip of what it looks like, and then what do you do to fix it next to it, right? Next one here is the PVCs. Here again, this is a premature ventricular contraction. So premature means it happens before it's supposed to. Remember back over here, the P wave or the atria is supposed to contract first, then the ventricles, okay? Well, here, what we see happen is the ventricle contracted before there was an actual atrial contraction. So we're missing that P wave preceding the QRS complex. So this is not normal. We need to have the atria contract, then the ventricles contract. Well, we skipped a step in this particular waveform. And so that's why it's referred to as a premature ventricular contraction. And so how do we fix that? Well, first off, make sure they've got plenty of oxygen. Lidocaine may be used. Again, that's not something you typically see as a part of your ACLS therapeutic regime, but again, that has been used in the past for treating PVCs. We just kind of put that in there for you. And then considering any other causes, anything that could cause hypoxemia or electrolyte imbalances could potentially cause PVCs. The next one there on page 45, letter G, is the multifocal PVC. So again, it's still a PVC, so it's a premature contraction, just looks different. So you can see this one does not look like this one over here. This one kind of goes upside down, this one kind of goes right side up, but they're both PVCs because both of them don't have a P wave before them, and there's a wide basal complex. It's a ventricular contraction. But you're going to treat it the same way that you did the other PVC. Page 46, ventricular tachycardia. Here again, we don't really see any atrial activity in between the QRS complexes, but we definitely have ventricular beats taking place here. And again, if you measure the distance between them, they are less than 3 big boxes. So that basically is a tachycardia. So you've got a ventricular tachycardia is what you've got. And then the solution for that is, if you've got a pulse present, then what you're going to want to do is cardiovert. Okay, and so you make sure would be a synchronized defibrillation is basically what that is. So you're kind of syncing it with the heart rate. If you have no pulse, then you're just going to go ahead and do a defibrillation, the CPR, and epinephrine amiodarone. So treat it basically like you would the next rhythm we're going to talk about, which is atrial fibrillation. So again, fibrillation just means quivering. This is a very chaotic rhythm. None of the waveforms look alike, or very few of them look alike, okay? As opposed to this one, where each one of these waveforms look very uniform. So that's how you can tell the difference between ventricular tachycardia and ventricular fibrillation. Fibrillation is chaotic, it's chaos. Whereas tachycardia, ventricular tachycardia, is going to be much more uniform. It looks the same, all the waveforms. Whoops. Okay, so ventricular fibrillation, we've already mentioned what you do for this. Defibrillate, of course. CPR would be a part of that, and the epinephrine and amiodarone would also be a part of the drugs. Again, you don't have to know dosages, you just have to know medicines that would potentially be used to treat it. All right, this next one is one that you got to be very careful on, because most people look at that and they say, yay, I got one I know. It's asystole, and they just pick it because they'll offer that answer up. But guess what? Make sure that you confirm it in 2 leads if you can, but they may not let you do that. But here's the real catch. Ask yourself, is there a pulse? Right? If you see this and they say that the patient is quietly sitting over there in their chair, eating their breakfast, talking to their family members, and you see this on the ECG monitor, do not call that asystole, because if the person was in asystole, they would have to be unconscious. So remember, the patient's alertness is going to tell you whether or not this is indeed asystole. If they say the patient is unconscious and has no pulse, and they show you this, then you definitely have got asystole. All right? So remember that. Page 47, ischemia, injury, and infarction. The first one here, these are terms that you need to be familiar with under letter A there, under number 5. The terminology ischemia means, of course, reduced blood flow to the tissue. Number 2, injury means acute damage to the tissue. And then number 3, infarction is necrosis or death of tissue. All right? So how do we know what's going on by looking at the ECG tracing? Well, if you highlight letter C, this is what ischemia looks like on the ECG. And now you don't have this circle in your study guide, so you may want to circle that depressed or inverted T wave. Normally the T wave will be bumped up like that, right? But it's not, it's going down. So that's an inverted T wave. So that would indicate ischemia. The next one is letter D there is injury, and it would be indicated by an elevated T wave. As you can see, it's way up here. Normally, here's the baseline. It should be down here. It's where it should be bumping up from, but it's bumping up way down. I mean, way up here, right? So that's, again, that's an indication of injury, which means damage to the tissue of the heart. And then this is an infarction. An infarction is Letter E, significant Q wave. So basically, again, here's the baseline, and you see that this waveform really drops down before it goes up, as opposed to the, as opposed to this one, you can see the Q wave right here doesn't really drop down that far, right? So here you can see a significant drop from baseline before ventricular contraction. And that would be an indication of an infarction. All three of these would indicate a risk of myocardial infarction. Something's not good going on with the heart, and we need to take a close look at that. Page 48. There is, this is the 12 lead. The thing that I want to emphasize to you here is, again, to circle this Roman numeral 2, this 2 lead. Remember, that's the lead that you want to monitor the patient in. That's the one that has the best indication of the axis of the heart, if there's any axis deviation, okay? And that's the main thing to remember. Each one of these, of course, is a different view of the heart, but this is the one we're going to use to monitor, okay? All right, so we are going to take a break at this moment. It's about time for one. Tom, is there any questions or anything else I need to go back over before we take about a 10-minute break?
No, not at this point. You answered the couple questions that they wanted you to go over.
Good. Okay, very good. So I'll go ahead and go off mic. We will resume. Let's see, I've got about, let's come back about 25 after. 25 after the hours when we'll come back. All righty, we'll talk with you then.